Our last talk is on the molecular profiling of tumor, and I request Professor Dr. Shahzad Qureshi. He is consultant histopathologist and also professor and head of pathology department, PGI and SIMS. Professor Dr. Shahzad Qureshi.
Actually, this is the state-of-the-art lecture, 30 minutes plus. So I thought instead of deleting the slides, I'd rather skip, and show you the interesting ones and, skip the very busy slides. But my lecture would be there in the system, so anybody can upload it, so you can have a copy of that. Right, G. So, we'll start from here. So it's a long journey. Actually, we started with, this microscope where we were dependent upon the sunlight. If there's no sunlight, we couldn't see anything. And now we have this genetic footprint. And so it has been a very long, interesting journey. So what exactly is personalized therapy? There are various names for that. You can call it customized medicine, targeted therapy, precision medicine. But basically, it is use of your genetic information in healthcare. So that is the bottom line. So it's a right drug for the right patient or the right person. And there has been a lot of improvement in cancer patients, especially advanced cancer patients. So this progression-free survival has increased. Overall survival has improved if you combine these drugs with conventional chemotherapy. So I'll start during my lecture from here. This is my mother. And she was associate professor in Fatima Jinnah. She was anatomist. So when she developed cancer, I think it was mid-80s. So I got the call from the oncologist. Tab yahan Shaukat Khanam nahi tha, so she went to MD Anderson, Houston. So I got a call from her oncologist that she has got brain mets. And she has got probably 3 months to live. So I said that I'm in UK. Is there any possibility she can live a bit longer, maybe 6 months, 2 years, so I can spend some time with her? But he said, no, that is the maximum. And exactly after 3 months, she died. But I was wondering that if she was living today, we might have given her maybe a year, 2 years, up to 5 years with brain mets. So that is how we have advanced so far. And this is a very interesting slide. This is a pub in Cambridge. And this is here from this whole story started of genomics. And in this pub, first time, Crick and Watson, announced that they have discovered the DNA structure, helical structure of the DNA. So it's a very famous pub in Cambridge. And this was the table. So I asked the waiter which was the table where Crick and Watson used to sit. So he said probably this was the one because near the window and his lab was just across the road. So he can see everyone going there. And this is amazing journey. This is 2000, I think, when the Human Genome Project was almost completed. And it took 13 years, $3 billion, and 6 countries to uncode the human genome, which is 3 sort of billion base pair and about 20,000 plus genes. So that was the first time it was discovered with so much of money. And now this small instrument do the whole job. So this is mind-blowing that this small instrument which you can put on the counter can do the job which 36 countries with $3 billion did just 20 years back. It's not a very long story. Right, so what we do basically, we do the genetic or molecular profiling of every patient who is going to receive these drugs, molecular drugs. So you can do the gene profiling, you can do the protein profiling, so the various methods how you can do it. You can do the whole genome, and NGS, which is the whole genome sequencing. And then you can target few genes. And then you can do the protein profiling also, which we do in histopathology as immunohistochemistry and protein microassay. So these are the different, this is immunohistochemistry we are doing regularly in different cancers, like HER2 in breast gastric, ERPR in breast, MMR in colorectal cancer, endometrium, esophagus. PDL1 is a very fashionable drug these days. You do it in non-small cell lung cancer. So this stands for non-small cell lung cancer. So ALK-ROS1, BRAF for melanoma, and now with melanoma, with brain mets, people are living for a good 5-10 years with these drugs. So FISH is another technique we are using to do the genetic analysis. And again, you can do HER2, ALK, ROS, MAT, MYC, TFE, and there's a whole panel you can do for different cancers. And this is how the FISH look like. You can see the dots if there is a trisomy, or if there's a translocation of the gene or amplification of the genes, so you can detect it through the FISH technique. Then you can do the reverse, your PCR testing, like for HPV genotyping, and to do the whole breast genetic sequencing. You can run the PCR. And this is gene microarray look like for whole gene sequencing. Now there is a panels for different cancers. So for like colorectal cancer, you do all these, you run all these tests. Like in lung cancer, you have a panel only for non-small cell lung cancer, not for the small cell. And then you have a melanoma panel. Similarly, you have thyroid cancer panel, pancreatic, biliary, glioma panel. So for different tumors, you run different genetic assays on this patient. So what are the genes we are interested in? So there are 3, in fact, group of genes which we are targeting, basically. So one is called the oncogenes, which are in fact related to cell proliferation and differentiation. Then MMR gene, which is the mismatch repair genes, which repair the DNA normally. But so if they are deficient, obviously the DNA will not be repaired, and the cancer will obviously have mutations. And this is the latest drugs which are immune checkpoint inhibitors, which we call immunotherapy. So actually immunotherapy is immune checkpoint inhibitors, and that is very promising these days in different cancers. So these are different targets. So you can see the center is the cell. Is the pointer working here? No, I think pointer is not. So this is in fact is the cell. So you can see different target which we in fact use to make the drug against, the target can be outside the cell, like growth factors. It can be on the cell membrane, like the receptors, then the signal transducing proteins, which bring the signal to the nucleus, and then the nuclear transcription factors, which are inside the nucleus. So immune checkpoint, I've told you, are the latest drugs, which is called immunotherapy. So we are giving in different cancers, like the patient with lung cancer, whom we used to give 6 months. Now they're coming back to us after 3 to 5 years, with absolutely no problem, So it's had been very promising. And this is how it works, In normal situation, the cytotoxic T cell and the tumor cells are, kept apart. But if you use the antagonist drug, like the receptor PDL1 antagonist or the inhibitors, then the cytotoxic T cell will attack the tumor cell and it will kill it. So this is how these drugs work. So there are 2 types of drugs we are using. One we call monoclonal antibodies, and second is the small molecule inhibitors. So there are different now, I can give you the example of these different drugs. Monoclonal antibodies, they bind and block the extracellular domain of the growth factor. They are large molecule, they are given IV only. Their example is cetuximab, Herceptin. So these are all examples of small molecule. And the immune checkpoint, these are the latest drug we are using in different cancers and as immunotherapy. And this is another kind of drug because the tumor is dependent upon the blood supply. So we are making the drugs which can, which are anti-angiogenic. So the blood supply will not develop within the tumor and the tumor cell will die due to necrosis and lack of blood supply. So this is how this drug, in the control you have the tumor, in the treated one, in which we give the antiogenic drug, the tumor disappeared because of no blood vessel formation. So this is how it looks like under the microscope. Small molecule inhibitors, they are small, so they can be given by oral route, very easy to take. Their example is EGFR inhibitor, ALK inhibitors, CMAT. So these are different example of the small molecule inhibitors. So this is a very rare tumor. It's called GIST, gastrointestinal stromal tumor. So even if they are metastasized, if you give these drugs, the tumor will disappear totally. And this is, you can see the histology, how the tumor cells have disappeared in treated patients. So there are few latest trials going on for different tumors. Like for lung cancer, you have EGFR mutation 19 and 21, which is floral trial at the moment. So although the jumps are not very big, but oncology, even the small jumps matters, If you can give from 6 months to 2 years, 3 years to the patient with advanced cancer, with metastasis, with secondaries, I think still it's a success story. So the median survival has increased in these tumors. And there is this ALK mutation trial, which is the ALEX trial, and 5 years survival has increased. Similarly, these are another Keynote 024 trial for, this is the immunotherapy which we are giving in lung cancers and other cancers and getting very good results. And melanoma, I've told you, people with metastasis are treated with these drugs, anti-BRAF, and they are perfectly fine even with brain mets. This is another trial going on at the moment, so again showing encouraging results. Then the metastatic colorectal cancer is the second commonest cancer, combined male and female. So they are also giving good results even with metastasis and giving good quality life. So, whenever there is a new technology, there is always some issue, some problem, like with artificial intelligence, with digital pathology, with telemedicine. So similarly, this is not exception. With this also, with personalized therapy, there are issues which we have to resolve. So there should be regulatory policies because to integrate the genetic information into your healthcare, it should be as confidential as the other things you use. The data protection should be there, and there should be a genomic reference lab. Then there is a problem with intellectual property rights. And this is important for the companies who are going to invest in these drugs because they're very expensive drug to make. So they have to make sure that no other person would copy that. So all the protection should be there. And then these are very expensive drugs and these are lifelong treatment. So obviously, like I work in UK, NHS is doing a good service, but when you overstretch any organization, there is a problem. So these are very expensive drugs, so how to, use that as a lifelong therapy. So actually, if you know too much about your genome, there is a problem, because there are very nonsense mutations also in your genome. It's, billion base pair, more than 20,000 genes. So any one, nucleotide, if misplaced, is it significant? Is not a significant? Should we intervene or shouldn't we intervene? So that has to be answered. So apprehension on the part of patient is very important. We have to reassure that this mutation is nonsense or it's not really going to affect you, and this one is important. So apprehension is there, true versus false, sense of reassurance. This I told you, significant versus insignificant genetic alteration, or intervention or no intervention. So what I've told you so far is that personalized therapy is the genetic testing, and after genetic testing, if that fault is in the patient, you will give those drugs. Otherwise, there's no use. We have very expensive drugs. So unless that patient is suffering from that particular mutation, only then you can use that. And then the regulatory policies have to be addressed. And the most important thing is these are not tumoricidal drugs. So we are not going to eliminate cancer. So we are trying to make cancer a chronic disease. Like you live with hypertension, you live with diabetes, you live with rheumatoid arthritis, whatever. So similarly, you can live with cancer as long as you take these drugs. So these are tumorostatic, but not tumoricidal. So that is the important message I think I wanted to take. So these are small jump at the moment, but future is bright, and I'm sure with time we can give hope to the patient with very advanced cancer, with metastases all over. So this is the last slide. So this shows what future we are going to hold. You can have an app in your phone. You can just pay now $100 and get your NGS done. And if you find any mutation, what are you going to do? So that is going to be the problem, I think, in the future. Right, okay then.
थैंक यू सर। चल आ जाए सर, क्वेश्चन का आंसर दे दें। ये फर्स्ट और लास्ट क्वेश्चन होगा हमारा।